Welcome to This Week in Cardiology. This week we're covering notable publications spanning advanced risk stratification in heart failure and hypertrophic cardiomyopathy, anticoagulation strategies in mechanical circulatory support, and the clinical necessity of deprescribing in cardiovascular disease. Let's dive in. We begin with new insights into risk prediction in heart failure, where traditional clinical models often fail to capture the complex molecular pathways driving disease progression. A new study from the Global Congestive Heart Failure Registry evaluated whether molecular risk stratification could improve prognostic accuracy in over 2,400 patients. Investigators analyzed 3 molecular scores: a cardiovascular polygenic risk score, a methylation risk score, and a novel 23-protein-based score known as proteomic death 23. Over a median follow-up of 3 years, during which roughly 8% of patients died annually, the 23-protein score emerged as the single strongest independent predictor of all-cause mortality. It more than doubled the risk of death per standard deviation increase, outperforming established clinical tools like the MAG-GIC risk score and even N-terminal pro-B-type natriuretic peptide. When clinicians combine this proteomic score with established clinical factors and natriuretic peptide levels, they achieved the highest predictive discrimination. Crucially, even among patients categorized as low risk by traditional clinical scores and natriuretic peptides, mortality rates escalated dramatically from under 2 deaths to over 8 deaths per 100 person years across the lowest to highest proteomic score turtles. Moving from heart failure to hypertrophic cardiomyopathy, a study published in the Journal of the American College of Cardiology provides a much-needed look at the natural history of phenotypically mild, asymptomatic disease. Utilizing the Sarcomeric Human Cardiomyopathy Registry, researchers tracked 2,500 asymptomatic patients with mild disease, defined as having a short disease duration, no prior major adverse events, Class 1 functional status, and a maximum left ventricular wall thickness under 25 millimeters. Over an average follow-up of 7 years, more than 1 in 5 patients experienced a major adverse cardiovascular event, including atrial fibrillation, malignant ventricular arrhythmias, or heart failure. The development of symptoms was a powerful warning sign. Patients who progressed from asymptomatic status to Class 2 symptoms or worse faced nearly 3 times the risk of a major adverse event. Baseline predictors of poor outcomes included older age, higher body mass index, larger left atrial diameter, greater left ventricular wall thickness, higher outflow tract gradients, and the presence of late gadolinium enhancement on cardiac magnetic resonance imaging. Furthermore, rapid remodeling over time was highly predictive. For every 0.5 millimeter per year increase in left atrial diameter, the risk of atrial fibrillation and heart failure more than doubled, while a similar annual increase in wall thickness doubled the risk of malignant ventricular arrhythmias. This highlights the importance of serial imaging and close clinical monitoring, even in patients who initially appear to have mild asymptomatic disease. Next, we turn to the challenging arena of mechanical circulatory support, where finding the optimal balance of anticoagulation remains a major clinical hurdle. In patients receiving extracorporeal membrane oxygenation, or ECMO, standard practice has long favored full-dose intravenous unfractionated heparin, targeting high activated partial thromboplastin times to prevent thrombosis. However, this aggressive approach frequently leads to severe bleeding. The RATE trial, an open-label, randomised, non-inferiority trial across 7 Dutch intensive care units, evaluated whether lower-dose strategies could mitigate this risk. The trial randomized 330 adults on veno-venous or veno-arterial ECMO to standard-dose unfractionated heparin, low-dose unfractionated heparin, or therapeutic subcutaneous low molecular weight heparin. The primary outcome was a composite of severe bleeding, severe thromboembolism, or all-cause mortality at 6 months. Both the low-dose heparin and the low molecular weight heparin strategies successfully met the criteria for non-inferiority compared to standard dosing. Although not statistically significant, the frequency of severe bleeding was lower in both the low-dose unfractionated heparin group at 58% and the low molecular weight heparin group at 59%, compared to 65% in the standard dose group. Importantly, This reduction in bleeding did not come at the cost of excess thromboembolic events, which remained low and comparable across all three arms. These results suggest that clinicians can safely lower anticoagulation targets or utilize low molecular weight heparin in ECMO patients, reducing the potential for bleeding-related harm. Finally, we address a widespread but often overlooked challenge in daily practice: polypharmacy. Patients with cardiovascular disease are frequently prescribed multiple medications, which can lead to inappropriate prescribing, drug interactions, and adverse events. To address this, the American Heart Association has released a scientific statement in circulation focusing on deprescribing. This statement emphasizes that polypharmacy is highly prevalent across the lifespan and provides tailored strategies for pediatric, adult, and older adult populations. The authors outline a structured approach to deprescribing, which includes identifying clinical cues and triggers, utilizing validated deprescribing tools, engaging in shared decision-making with patients, and leveraging the entire healthcare team to overcome systemic barriers. Rather than viewing cardiovascular guidelines as a mandate for indefinite therapy, this statement urges clinicians to actively evaluate when medications are no longer serving the patient, transforming deprescribing into an active, evidence-based component of comprehensive cardiovascular care. If you only have time for one paper this week, make it the RATE trial. This landmark randomized trial provides the first robust, high-quality evidence that lower anticoagulation targets or low molecular weight heparin are non-inferior to standard full-dose heparin during ECMO support, offering a practical pathway to reduce bleeding complications without increasing thrombotic risk. Here are the key takeaways from this week in cardiology. First, the RATE trial demonstrates that low-dose unfractionated heparin or therapeutic low molecular weight heparin are non-inferior to standard dose heparin in ECMO patients, supporting a shift toward lower anticoagulation targets to reduce bleeding. Second, a novel 23 protein score, proteomic death 23, outperforms traditional clinical risk scores and natriuretic peptides in predicting mortality and heart failure, highlighting the potential for molecular-level risk stratification. Third, even phenotypically mild asymptomatic hypertrophic cardiomyopathy carries a significant medium-term complication rate, with rapid increases in left atrial size and wall thickness over time, doubling the risk of adverse events. And finally, the American Heart Association's new scientific statement provides a practical framework for deprescribing in cardiovascular disease, encouraging clinicians to systematically address polypharmacy across all age groups. That's your roundup for this week in cardiology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. One more note before you go. Only 4 new papers of note met the bar since the last update, a quieter stretch for new literature. Still worth revisiting from recent updates. AHA-ACCESC/consensus document. Second Universal Definition of Heart Failure, 2026, in European Heart Journal. And Antiplatelet Therapy in the Management of Atherosclerotic Cardiovascular Disease, 2026, ACC Scientific Statement. A report of the American College of Cardiology, in Journal of the American College of Cardiology. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.